And I am going to stream live on Facebook. And give me 1 minute, Adam. I'll tell you when you're ready to go.
Okay.
Oh, here comes both Vanessa and Bryce.
Excellent.
And Adam, I'll probably turn off my video and phone when others are talking.
Okay.
And are you going to field questions? Is this or is this kind of an organic?
Yeah, well, Carla's going to lead us, and then we're going to have questions that people are posting on Facebook, and those will be put into the chat.
Okay.
And then Carla will decide when she wants to go to the chat and pull one of the questions.
Okay. And I'm sure they have a few in their back pocket to ask just in case.
Yeah, we have some to get started.
And we're recording. Are we recording this one?
Yeah.
Okay.
Yeah.
I think so.
And give me. You are live.
All right. Thank you, Shelley. Thank you, everyone who's tuned in. Tonight, we are having our weekly community conversation, and our topic is CFP and AAFP advocacy on behalf of family physicians during the time of COVID. I am Adam Francis. I am CFP's Director of Government Relations. Hosting our panel tonight will be Dr. Carla Kakutani. She is a CFP past president. She is also a past president of the Family Physicians Political Action Committee. She is our current Legislative Affairs Committee chair. And also joining us is Stephanie Quinn from AAFP. She is the AAFP Senior Vice President of Advocacy, Practice Advancement, and Policy. We're also happy to have Vanessa, Cajina, and Bryce Docherty, who are our legislative advocates in Sacramento. You'll also see that Lisa Fulberg, our CEO, is here. And I'm not sure, but we have other staff members, including Shelley Rodriguez, Josh Lunford, and Morgan Cleveland. Thank you all for joining us. Carla, I'll hand it over to you, or maybe you can do your own little brief background about how you've been involved with CFP and AAFP.
Okay, thanks. I'm glad everyone could join us. One of the key things, one of the reasons we wanted to do this tonight is to remind everyone and fire everyone up for not forgetting about advocacy during this time. I know people's heads have been full with all kinds of things for their families, for their practices, etc. But it's also really important that we not lose sight of what's going on in the government, both state and federal, and that people pay attention to that and can help us try to advance some of our family medicine issues during this time. So I'll just to start with, I'll let some of our folks introduce themselves. Let's start with Vanessa.
Thank you, Dr. Kakutani. My name is Vanessa Cajina. I have been a lobbyist or legislative advocate for about 12 or 15 years now in Sacramento, and had the displeasure of living through the past budget deficit. But we have been working on behalf of the family physicians in California since the beginning of the year. And prior to this, I worked for state Medicaid advocacy at the state level at the Western Center on Law and Poverty, and have a lot of experience in public programs administration. So, you know, there's a lot to be dialed in on right now, and we need your voices more than ever, and really appreciate you taking the time tonight.
Great. Stephanie, how about you?
Hi there, I'm Stephanie Quinn. As of June 1st, I will become the Senior Vice President of Advocacy, Practice Advancement, and Policy. I am currently the Director of Government Relations at the Academy. I've been here for about 8 months now. Prior to that, I was with Care First Blue Cross Blue Shield, and before that with the radiation oncologists. And prior to that, another 10 years with Blue Cross Blue Shield New Jersey. So I come with kind of a mix of physician and payer background, which has, I would have liked to have thought prepared me for this somewhat unprecedented time, but as I'm sure I don't need to tell any of you, it has been challenging. So your engagement is very important, and we are so proud of the work that you do and working on your behalf every day.
Thank you. And how about you, Bryce?
Yes, hi. My name is Bryce Docherty. I'm with KP Public Affairs. I head up, partner there, I head up our healthcare advocacy practice. So Vanessa and I handle that, those stable of clients. All of our clients are provider related. So in addition to the benefit of being able to represent family physicians, we also represent the California Society of Anesthesiologists. We also represent the California Ambulatory Surgery Association, orthotic and prosthetic providers, hearing aid dispensers, and a host of other healthcare provider-related clients. I started with the Michigan State Medical Society back in the mid-90s, and came to California for graduate school and spent about 5-6 years with the California Medical Association and their lobbying shop, and started my own firm several years ago and represented several specialty societies, not least of which are the ophthalmologists, and we've represented orthopedic surgeons, psychiatrists, and physician assistants. So been doing this for a while, and it's really been a pleasure to be representing family physicians. And we had a lot of momentum prior to COVID, and I think we are actually well positioned to amplify the voice of primary care, physicians in this time of crisis, and hope to have some good discussion on it and answer a lot of your questions. Thank you.
Thanks. So those of you out in Facebook land, you can, in the comments, if you think of questions, please type them in, and we'll be looking at those and weaving some of those in there. I think the first thing, though, we're going to talk about a little bit is the biggest challenges that family physicians have faced since the start of this crisis. And I'll just throw out a couple that I have been hearing about or experiencing, and let some of you folks kind of feed back to us how you're seeing this play out in the advocacy world. I think one of the biggest ones is how practices and how are they going to survive financially during this time. A lot of obviously everyone's business has dropped, and in a fee-for-service world, that's tremendously difficult. There was a little bit of help, thank you AAFP, a little bit of help with Medicare being able to prospective payment, but for a lot of people that's not nearly enough. So would any of you guys like to chime in kind of on that topic?
Sure, I'll start. From very early on, we were particularly concerned about this. There is a survey that's been in the field for a number of weeks by the Primary Care Collaborative that has been gauging the effect of COVID on primary care practices. We were pretty alarmed by the responses about the challenges that primary care physicians were having, and so we put our own survey out to our members. And 90% of the respondents said that they were very concerned or somewhat concerned about the financial viability of their practices. And so we jumped into action. We were working with AFP on pushing different measures there. We currently have an advocacy campaign going on where we hope to somewhat mirror what Medicare has done, and I'll let Stephanie talk about the Medicare program. But in California, our ask right now of legislators is for them to require health plans that are contracted with primary care physicians on a fee-for-service basis to pay them the same amount that they paid them last year for March, April, May, and June, and to continue those payments until the state of emergency ends, and then build off of that to transform our primary care payment system into one that more values primary care, pays it to do the right things to keep people out of hospitals, to deliver the right care at the right time in the right place. And so that's something we've asked of legislators and continue to ask of legislators. And later on, we can talk about how you can help out with that. But I'll kick it over to Stephanie to talk about the federal action.
Thanks, Adam. I think our work really focuses in 3 buckets. The first is around the supply chain and the concerns there, whether that's with personal protective equipment. We're now hearing concerns about availability of hypodermic needles and that there could be shortages there. We are concerned about point of care testing and making sure that it's making its way out to practices, and really trying to reinforce that hospitals obviously need to be well resourced, but that is not the sum total of how care is delivered. And so we need to make sure that we are responding in kind to community-based practices throughout the country. The second bucket is really related to kind of the workflow transformation. So the drop in in-person visits had a devastating and immediate impact on practices. And so quickly trying to ramp up a telehealth infrastructure where before there was none required us to really focus in on areas where there was little to no broadband support, and really trying to secure resources to address that. But overall, I think when it comes to telehealth, I think our goal was to make sure that for all the time and investment and energy, that it's integrated in a meaningful and long-lasting way. And so one of the first issues that we noticed was that telephone only was not reimbursed by Medicare at all. And so we weighed in with them very quickly, and they responded and covered that. And then we realized that those payments were significantly lower, and a lot of seniors only have access to phone only. And so we pressured them to really address the parity issue there. We also were interested in kind of the coverage provisions and making sure that there weren't financial barriers to accessing testing and the related treatments. But I think beyond that, the one where we spent the most of our attention is really on the financial stability, and that's kind of two-pronged as well. And so there's the near-term stability. How do we make sure that practices can keep their doors open to continue to see patients and provide the critical chronic disease management that all the strides that we've made to make sure that we don't have major steps back with these practices closing, but also how do we move from this fee-for-service structure that we see a perfect illustration of how it does not service primary care, and how do we get into something that is more perspective facing and therefore more sustainable. So we actually asked Congress to issue those periodic interim payments, which is what then became the accelerated and advanced payment program, recognizing that Medicare is not a total portion of the patient population, but really trying to get some help in there. And they halted that program several weeks ago, and we are encouraged that there is congressional interest in having that program reinstated and with more favorable terms. So I think that we're really encouraged by that, but I'll stop there for now.
Okay, thanks.
Well, I think you brought up a great point with telehealth. We in California have been very active on that before COVID. So we were able to pass a bill last year. I think it was AB 744 that would require, starting in January 2021, require all health plans to pay for telehealth visits at the same rate as in-person visits. So it hadn't gone into implementation yet, but the state was very responsive to our request to start that early, and they started that very early on in March to implement that sooner, and that made a huge difference, being able to have that payment rate be equal to in-person rates. And of course, the amazing work that AFP did at the federal level for phone visits, because we had been hearing from a ton of our physicians that they were very thankful for having that telehealth payment increase, but a lot of their patients may be elderly and don't have a cell phone, don't have access to Zoom or broadband, and having the phone rates be the same as the in-person rates was monumental. So fantastic work from AFP there, especially having it predated back to March 1st. I imagine that was a huge lifeline for our physicians.
Yeah, I can't tell you how many times I've turned a telehealth visit into a phone-only visit because it's just not working on the other end at all. Vanessa and Bryce, how do you see the California being able to move the other payers towards this prospective payment?
So we started at the beginning of the year having some conversations with legislators prior to the pandemic really setting in California, and that, you know, at least gave them some ideas on what a prospective payer system might look like here within the state. So we got a lot of good language from CAFP, from AAFP on using our state health and human services agency as a convener to get around some federal antitrust issues that exist there. If you're bringing in multiple payers, they can't really have a conversation about what payment systems look like, what incentives look like, without running into those antitrust issues. So we were able to start with that and germinate with that, and we were trying to run it through the budget process, but then, you know, clearly everything blew up in the course of a pandemic. But we've been able to now pivot and use what we learned and got instruction from on the Medicare on the piece on at the beginning of this, and say that this would be a really good way for the state to utilize its commercial payer sources on fee-for-service to make a bit more equal than what's happening on the Medicaid side, Medi-Cal in California, and, you know, use that as the emergency payment system to keep systems whole right now in conjunction with telehealth, to just keep everything afloat. But we've also gotten some good response from our state health and human services secretary, who now wants to convene some discussions amongst his staff on what this more holistic model would look like. You know, we've had some success with value-based payments in the state, but only on the Medi-Cal side. So seeing what that would expand to an entire patient population with, you know, that's so critical right now. I think that we have people's ears, and it's an awful thing that we have to use this opportunity to do it, but that's where we are. And if we can move those conversations, then that's what we're going to do.
Great.
Yeah, the only thing that I'll add is we did start the year focusing on a song Brown, and we were focusing on trying to find, for this very reason, trying to find non-general fund revenue to support the program. We're just north of $33 million annual ongoing funding in Song Brown. Then COVID happened, and then we're having to bridge somewhere between a $30 to $54 billion budget deficit, which is a challenge. So in a matter of 7 weeks, like a lot of family physician practices that were turned upside down, the capital was turned upside down and shaken, and we went from being very assertive and proactive to being in a defensive posture. And the governor's May revise came out on Thursday of last week, and we've mobilized at CAFP very quickly to pivot to prospective payment and to pivot to looking at ways in which we can provide value-based reimbursement for primary care physicians. And I think the prospective payment piece is going to be getting some traction. Anything we could do to try and tie that to the Medicare or the Medi-Cal program, because we know we're going to see increased caseloads on the Medi-Cal side. And I think there is some appetite, because even though practices have diminished, patient cases, somewhere between 50 to 80% decrease, but everybody's still paying their health insurance premiums. So the first quarter, profits from a lot of the health plans was just as robust as past years. So I think in terms of trying to come up with money to support family physician practices, we think the prospective payment concept has legs. We're also going to be doing some stakeholder outreach. I know CMA is working on a lot of proposals, but also with CPCA. So we're trying to amplify that messaging by, working with some of our industry partners. So we think there is a lot of promise in that. We also were targeting places where we could find additional revenue that weren't general fund based. And so we were looking at things like an e-cigarette tax or a vaping tax, and repurposing some of those monies towards training primary care physicians in California. That was well on track. And then now there is discussion about using some of those funds to support the additional caseload in the Medi-Cal program. So I think when you're going down the list of folks who the legislature is going to be looking to in terms of frontline providers, the folks that are actually providing that care and the intake for the healthcare system, I think they've always looked very fondly on family physicians. And I think we need to be part of a larger ensemble voice at the state capitol, but we're also trying to position ourselves and a lot of the outreach we've done to a lot of the members over the last week or week and a half, and a lot of the work that Adam has done has been to try and to differentiate ourselves from that crowd a little bit. And I think we've got a great story to tell, and we're just now kind of starting to tell that. And most of that will play out over the next couple of months. The state budget has to be signed by June 15th to take effect on July 1. A lot of the budget that's going to be passed has a lot of what we call trigger cuts. And a lot of that, Stephanie, is going to be contingent upon federal funding from the federal government. We know that Congress passed 2 nights ago the $3 trillion relief package for states, led by Nancy Pelosi, our congresswoman from San Francisco. The fate of that in the Senate, we're not quite sure, but I think what the governor was saying on Thursday was, we're prepared to make very difficult, painful decision and cuts to a lot of healthcare programs, because that's really the only space in the state budget where the legislature still has some discretion on spending. We do a lot of ballot box budgeting. So 40 cents of every dollar the state takes in goes to Prop 98 to support schools. So when it comes to cuts, we're the first ones somewhat on the chopping block. So if we're able to draw down, I think what the governor has earmarked is $51 billion from that $3 trillion package. We would kind of stave off some of the cuts that we need to do, but we're not waiting for that decision at the federal level to be made. Yeah. We're actually now advocating to say now is the absolute wrong time to cut services and funding for primary care physicians or primary care physician training programs. It's ill-advised, it's misguided, and we'll find out this week, quite frankly, whether or not those proposals have legs. We've got an Assembly Budget Subcommittee on Health that is meeting on Tuesday of this week. And then the Senate Budget Subcommittee will be meeting next Saturday. So a lot of this work is happening now. So keep those phone calls and emails and outreach to your legislators coming.
Yeah, we're gonna get a little more into that in a minute. I also had a question. A lot of our members, Stephanie, are work for FQHCs. And what's the latest and greatest on how they're being supported during all of this?
I think one of the important changes was, again, relating to telehealth and allowing them to be an originating and distant site. In addition, this proposal, I think the House version has an additional $7.5 billion for FQHCs. And I think we're using that as an opportunity to message on the fact that you recognize the importance of this kind of care. This really needs to translate into all primary care settings. And so we've made sure, we've tried to make sure that any kind of flexibilities that they're needing to be successful and really pushing for that extra funding has been critical. I mean, there were some that were initially excluded from receiving the paycheck protection programs because they receive municipal funding. And I think that is something that has been remedied in previous iterations, but that's something we need to get across the finish line for them to qualify where they can, for assistance where they can.
Great. Let's see. Have we had any questions from the field yet?
Not yet, but I'm going to quickly go back just because we might have people on Facebook who are new to CFP advocacy and may not know about all the different programs. The Song Brown Primary Care Physician Training Program is this really amazing funding source for primary care physician residency programs. Back in the 70s is when it was created by CFP in the state. It was only a family physician program at that time, but has since expanded in both money and in specialties. It now includes nurse practitioners and PAs, pediatricians, OBGYN, and internal medicine. It is a fantastic program. Up until about 5 years ago, it was only funded at about $3 million. And that was to go to support residency programs in underserved areas, serving underserved populations, graduating minority physicians and physicians who stay in primary care. So, I mean, hitting almost every single goal we have for advocacy in terms of pipeline, getting physicians where they're needed, representing the community, and staying in primary care. CFP and our residency program directors and members did an amazing advocacy job back in 2016, having legislators come tour their residency program, showing them the value of their programs, how their physician residents are not only being trained, but seeing patients all throughout their training at a rate of at least 600 patient visits per year. Those physicians then go on to stay, the vast majority of them stay and practice in the region. So truly a win-win for the state and for primary care. And we're able to get a $100 million three-year infusion of funds for that program. Since that time, we successfully advocated for Gavin Newsom to continue that money, $33 million a year. Unfortunately, because of COVID and the budget deficit, the governor has decided that that $33 million should be cut during this time. We think it's the exact wrong thing to do. This program has been extremely successful, getting more than 23 new residency programs into underserved areas. And it should be the last thing we should be doing when we're trying to battle a pandemic, is to hurt our primary care workforce. So we'll be asking all of you to reach out to your legislators to let them know that while $33 million is a very tiny amount compared to the $54 billion that we need, that tiny little amount makes a huge difference in terms of patient health and access to primary care. So find that tiny amount somewhere else. Again, we're hopeful that we can get some action done at the federal level to help states out, but we're not relying on that, and we need everyone's help to make sure this program can be saved.
So I'm going to jump in here because there was a clinical question from one of our members, Dr. Kumar, who wanted to know about, can somebody comment on the antibody test for COVID-19? Patients have been asking for it. I'll comment. I'm certainly not the world's expert, but our local labs have been offering it now for about 2 to 3 weeks. And I'm been ordering it for anybody who wants it, with the proviso that they understand that we don't know what it means in terms of immunity. And I'm not guaranteeing that their insurance is going to pay for it. So that's my little spiel that I give when people ask for it, and then I go ahead and order it. And interesting enough, I'm 0 for 5 in terms of folks who are convinced that they had something in February or January, and they do not, nobody has had positive antibodies so far. All right, going on.
I just real quick, I am
Sure.
certainly not a doctor in any means. I don't even play one on TV, so I won't attempt to address the antibodies questions, but I will tell you, if you're looking for up-to-date info on COVID-19, I highly recommend AFP's response to COVID website that you can visit. Just type in to Google AFP COVID-19 and it'll pop right up. CFP also has resources on our website for COVID information. I posted that now on the link here, so hopefully you're all seeing that. Those are, I would say, really go check those sites out if you have more clinical related questions. All of us just pretend we're doctors, except for Carla, of course.
So here's a kind of a technical question for our folks on the call tonight, from Carol Havens, who is a legend here at CAFP. She wants to know how, when you're working with different specialty groups, how do you guys handle it when there's a disagreement about what to do next within what you were hoping would be coalitions?
This happens all the time. You know, we come together when we can, and we actually work pretty closely with what we call the group of 6. So that's us, that's AOA, that's ACP, that's ACOG, did I say APA? And AAP. And we try to, when we can, we will issue joint statements, we will comment on things, but a lot of times we're out there representing our specialties the best way that we can. And so I think that we take those disagreements in stride, and I'll give you one real example. As you know, this year's physician fee schedule came out with an evaluation and management increase of 12%, which obviously is something very beneficial to primary care clinicians and physicians. And a lot of the procedural based specialties were very unhappy about that and have since taken to the hill before COVID and even now trying to push back on that, because in a zero-sum game, for someone to get an increase, someone gets a cut. And so there are people out there every day that are working against interests other than ours. And right now, one of the things that they're doing is they're trying to stave off the implementation of the fee schedule, which we are very much opposed to and fighting hard against. And their, I guess their consulate or their kind of contingency plan is to ask Congress to waive budget neutrality so that those cuts won't go into place for them and we can maintain our increase, which is something we're keeping a very close eye on, but a long answer to a short question.
We had Blair Cushing was asking, what kind of feedback are we getting, both Adam at the state level and for you, Stephanie, at the national level, about people just having to close practices? Are we seeing that already?
Certainly, AFP had, well, I don't know. I imagine AFP was working. There's been several newspaper articles about this, interviewing different physicians who have been challenged with the financial hardship of COVID. Stephanie, could you talk a little bit more about that?
Yes, we've actually quite early on, we were getting calls from practices actually asking for practical advice about how to close down their practices, which was very alarming for us. And some of them have, we've heard that some members are retiring early. They are, some are closing what they hope is temporarily. And I think the concerning thing is that some of them applied for every available assistance, whether it's Paycheck Protection Program or the accelerated advance payments or provider relief fund, and didn't get anything. And then there were some that applied and got it, and it still wasn't enough. And so I think that this is something, in Health Landscape, we actually, they modeled out kind of an attrition model of the expectations of potential practice closures. And I think we can't think of it in a static sense. If a practice makes it through May, they may not make it through June. And if they make it through June, they may not make it through July. So, I mean, we could be looking at this on a rolling basis. We are working really, really hard, recognizing that this is a concerning trend.
Yeah, and certainly if you know of anyone who, a primary care physician who is having this challenge, please get them in touch with us. We really need to amplify their story as much as possible. I don't think legislators truly understand what is happening and what it will mean if those practices close. I know we have a very active physician in Taft, California, whose clinic is now going down to 3 days, and they're probably the only healthcare source in the entire city. So it would be completely devastating to lose these practices. And it's very, very likely they are not coming back after this. So we need the legislature to act immediately to step in and make sure that they can be made whole and they can survive this, because the effect will not be only immediate; it will be long term.
Yeah, and as we all know, the individual stories that are told make way more impact on legislators than just talking about things in generalities.
And actually, to that end, sorry, before we go on, but to that end, we are building this as we fly, but I think we have seen the need, especially kind of in a social distancing environment, for members of Congress really to be able to hear from their constituents what's happening on the ground. And one of the things that we're pulling together is what we'd like to call a virtual Hill Week, being that we couldn't have our FMAS, which would have been starting this evening. So what we're going to do is we're going to pull together a group of activities and members can take one action, they can take all the actions, whether you're contacting the office and trying to set up a meeting such as this to speak to them, whether it's sending a short video message and tagging your member of Congress, sending tweets, sending speak outs, and really letting them know. And there will be some accompanying materials to kind of talk you through some of the issues and some of the pieces of legislation and proposals that are in front of them. And our hope is that, I mean, those stories really help put a finer point on the things that we're working on every day, to be able to say what these things mean to a person, to a practice, to a community. Nothing is more effective.
So I was going to ask you guys, you know, especially when it comes to advocating for training funds, Song Brown, I can think of some other ones on a more federal level. And obviously people are going to push back and say, well, we've got this huge hole and we need to pay for the patients to have access to Medi-Cal, for example. And as a physician, I'm always torn, because of course I want my patients to have access, have health care. So we're kind of looking at two different things. We're looking at the short term, you know, gosh, the state needs to stay whole and it needs to be able to, you know, get people some basic Medi-Cal. And then the longer term vision, which is if the rest of us are gone because we couldn't keep our practices open, doesn't matter whether they have Medi-Cal. Can you give us some great ideas of how to handle that dichotomy when we talk to people? Vanessa?
What I have appreciated is that the budget, at least in California right now, seemed to try to split a difference between what we need to do to stave off the short-term bleeding of just precipitously decreased revenues, and with what the long-term is going to look like. So there is a lot of shared pain across the board. I think the administration was more mindful this time than we have been in previous deficits of trying to maintain some semblance of a primary care delivery system. However, that has still left us in a place with a short-sighted cut to Song Brown. And we have been pressing, you know, in the last couple days since the revision to the budget came out, that we're already in a really poor spot with access to primary care. And it does seem to be, you know, resonating with members of the legislature that this cut, the multiplier effect becomes immediate. So we've been somewhat successful with that, but you know, still to that extent, we really need folks calling to their legislators' offices right now, because it's critical that we keep this funding, because as many people as we can keep moving through the system, we're actually serving patients to make sure that we're taken care of on the front end. Even if there's delivery systems transformation with telehealth, with payer delivery systems, all of that, it doesn't come without actually having the clinical expertise in front of you. So that's the message that we've been providing and that we hope carries the day.
Sounds great.
And Dr. Kakutani, I also would like the group to understand that we are, if there's any sort of silver lining in this whole process, in this budget crunch, is there's only 2 physicians elected in the state legislature. One is Senator Richard Pan from Sacramento, whom many of us know, pediatrician. He's not only chair of the Senate Health Committee, obviously the policy committee, but he's also chair of the Senate Budget Subcommittee on Health. And then the other physician on the Assembly side, Dr. Joaquin Arambula, ER physician from the Fresno area, is chair of the Budget Subcommittee on Health on the Assembly side. So a lot of these discussions are not falling on deaf ears. They're actually very engaging discussions that you're going to have with at least those 2 members. And Vanessa and I, in fact, had a discussion with Senator Pan on Friday, and he helped steer somewhat of our messaging. And you know, I would agree with Stephanie that it's important for us to do the ensemble House of Medicine stakeholder advocacy, but there's also certain bits and pieces of those points or objectives that kind of need to be amplified. And I think we're really in a unique position to at least have those 2 legislators, you know, with us, and we're quite frankly under their wing a little bit, trying to take some of their guidance, to try and provide them some constructive ways to help leverage or at least get primary care physician practices through this crisis.
Great.
And I would add to that, first, that we've advocated for funding for teaching health centers, which is only reauthorized through November. And we continue to push home on that message. And just that teaching health centers, it's not just about training the workforce, they're actually delivering care, and the communities where they're delivering care are critical access points. And so, yes, we definitely understand that it's a difficult balance just because people want to deal with the immediate and what's in front of them. But we're also telling them this is signaling to a younger workforce that's coming up the pipelines. If funding is unstable, you are sending a message that this is not supported, and that will have long-term ramifications that will go beyond anything that we're able to do with patchwork funding. As far as the messaging piece, I would say one of the things that I would recommend is that, especially, in talking about being made whole is kind of a non-starter, and it really gets their back up because they feel like people across the country, no one is really going to be made whole after this whole thing. And so being targeted and specific about what your needs are to meet the needs of your patients is the most important. And then really focusing on the care piece, because they're hearing from industries all over the place where people are losing jobs or they're closing businesses, and the economic impact of that, which is obviously important, but it cannot be understated the type of care that family physicians deliver and what is really hanging in the balance. And this is where I'm not afraid to put a lot of distance between us and our specialty friends to say, you know what, it's not the same, and this isn't to malign anybody but this is really something very different than some of those other specialties. And so we're pretty out there with that message.
Great. I think at this point, Adam, would you like to start the whole discussion about what we're going to do in the next couple of days to talk to the budget folks?
Yeah, it's a great, we've serendipitously worked out this advocacy time because as Stephanie mentioned, and I'll let her talk about it in a little more detail later, they're having their week of advocacy starting on June 1st. And for us, that advocacy starts tomorrow. The budget is due to be passed on June 15th, but the decisions will be made this week. And so we need everyone out there to get involved. Hopefully someone can post on Facebook right now the link to our site that lists out all the different actions that we'd like people to do, but we have 3 very specific asks that we want you to make to your state assembly person as well as your state senator. We want you to call both their Sacramento office and their in-district office. We've heard stories that some of the Sacramento offices aren't even taking voicemail. A lot of legislators aren't there in person, and so definitely please call their in-district office as well. Our 3 asks are that, 1, do not cut Song Brown. As I went and discussed in detail before, I won't go to it again, but a very important program to family medicine and primary care workforce, both in terms of the present and future access to care. The second is to ensure that we have primary care practices not collapsing under fiscal strain, losing access to care for hundreds of thousands probably in California if those practices disappear. We think health plans need to share in the solution to this problem and begin paying those fee-for-service practices the amounts they were paying them last year in March, April, May, and June. And then to build off that, we would like the state to convene payers, purchasers, consumers, providers, patient advocates together to talk about what we can do so that primary care doesn't face this situation again. That we have a system that values primary care, that values preventive care, that pays primary care physicians in a way that most allows them to take care of their patients, to improve health, rewards them for improving health and containing costs. We have plenty of evidence to show how effective primary care can be if it's actually supported. And so we need to finally get together and make those changes. So we're asking you to call your legislators this week. This week is decision time, and we need everybody. It doesn't matter if you are fiscally suffering or not. We need you to help there and be supportive of your colleagues. if you have a residency program in your district or not. You certainly went through residency, and you can testify to the fact of what you were doing during your residency program, how you were taking care of patients, particularly Medi-Cal and the underserved. This is a really important message that we need to let legislators know. They're not necessarily very familiar with what a residency program is. Some are, some aren't. And it's really important that they understand how important they are to the community. Bryce or Vanessa, do you have anything to add about this week in terms of advocacy?
No, I don't think so. I mean, I think that timing is right. I think we need to establish that beachhead now. I think we need to be mindful of the fact we don't want to be seen as tone deaf. We do understand that the state is in terrible financial crisis. Schools will be cut. I mean, we're not the only ones on the chopping block. So I think our messaging is one of frontline defense at a time when healthcare services are in short supply. Number one. Number two, I think it's a function of message discipline. And I think it'll be an exercise in repetition. And I think each family physician's practice and the way it's constituted, and whether you're working in an FQ or a rural health clinic, what have you, I think there are a host of similarities, but I think it's also, to use one of Gavin Newsom's terms, localism is determinative. So if you can, parlay the unique experience that you're having in those districts with those legislators, it just kind of helps amplify what we're saying. So we need to start now, but also keep in mind that we have extended, as the federal government has, we have extended our tax deadline to July 15th. So typically we have, the governor comes out with his May revise, which he came out with Thursday of last week. Now, the May revise is called that because it's an adjustment on his January budget proposal based on what the tax revenue looks like. So that tax deadline has been extended until July 15th. And so depending upon what happens at the federal level, depending upon what those tax receipts look like in July, the legislature will be in session until the end of August. And now we're talking about what is commonly being referred to as an August revise. So we need to make ourselves known now and be prospective and be assertive, but also keep in mind that this is not something that we're going to do next week and then we're going to walk away and Jesus take the wheel, if you will. This is something that we have to be mindful of, and it's going to be week after week and month after month, but I think we'll know definitely where we stand by the end of August.
Great, appreciate that. Let's see. So one of the last questions I had on my list was, right, kind of going with you, Bryce, where you were headed there, was that obviously this is not going to be the end of all of this. What do you see the next hurdles once we get maybe past this initial crisis with our advocacy?
I hope that there doesn't come to be a lot of advocacy fatigue within our community, because we're going to need people in this for the long haul. It is very difficult to face a cut right off the bat, like what they're making to Song Brown, and still feel like our voices have value to them. But for the most part, there will be proposals that are made this time that don't make it to the final budget this time. They might come back in August, depending on what the fiscal impact on the state is. And we're going to have this fight for some time to come. We need to buttress wherever we can. So I hope that people will stay vigilant in terms of what our advocacy asks are, and are also consistently dialoguing with us so that we know what's going on in your community, so that we know what your impacts are and what the effects on patients are. So I think that that's going to be one of the bigger challenges that we're already feeling right now, is the fatigue of all of this, and we're sympathetic to it. But the only way to get through it is to work through it, and we hope that we can all count on each other for that support. Yeah,
the Nonpartisan Legislative Analyst's Office predicts that we're going to be seeing $20 billion shortfalls for the next 4 to 5 years. as a result of this. So this is not going away soon. We need to definitely fight in the short term immediately to shore up what we can. But this is just the beginning, unfortunately, and we all need to work together to make this happen.
And I think from the Academy's perspective, one of the things that we're looking at is there was an incredible amount of activity to try to prepare and respond to this pandemic. And some of those things, are right and appropriate and should remain in place. And some of those things may need to be scaled back. And so we're working quickly to say, okay, what was temporarily suspended that really needs to go on in perpetuity? And what are some other things that really could leave us at a disadvantage? And some of those revolve again around telehealth and making sure that the flexibilities that were extended don't have the unintended consequence of favoring some other platforms and potentially disintermediating that patient-physician relationship and making sure that the flexibilities make sense, are clinically appropriate, and actually preserve that. And then other reporting was suspended. Some prior authorizations were waived. And I think if we can construct a scenario where people can still conduct business without these burdensome processes, doesn't that mean that there should be a path forward? So we're looking at all of these things and saying, what should we be thinking about promoting to stay in place in the future?
That's a great point, because one of the things Adam and I were talking about this last couple of weeks was, we had this vision of we were going to ask the state to convene these payers and all these stakeholders to talk about prospective payment and a whole different, way of funding primary care. And at first it seems like, well, that's out the window, but there are opportunities in crisis, and maybe this shakes things up to the point that we can get rid of things that don't work and bring in new ideas and new ways to structure stuff. Other comments out there?
I would say to build off of that, this administration, the Newsom administration, and the fantastic staff he has working for him are really interested in that. They were interested in that pre-COVID. They had proposed some pretty aggressive reforms in Medi-Cal, California's Medicaid program, in terms of behavioral health and care coordination. And we were very excited about where that might go. An Office of Healthcare Affordability, something we were very concerned with as well. So they're very interested in this. They have a background in this. Alice Chen, physician from San Francisco, very interested in this. The Secretary Ghali, the Health and Human Services Secretary, a pediatrician from Los Angeles who'd been very involved in patient-centered medical home activities. So I would say, at least in my time at CFP, we've never had a more knowledgeable and supportive administration in terms of healthcare and healthcare knowledge. And it's unfortunate that that the whole world has come crashing down, because I think we could have done a lot of really, really amazing things, but it doesn't end the possibility that we can make some important changes. And as long as, we'll be very active in reaching out to them. We are walking and chewing gum at the same time. We are dealing with this crisis, but we also have an eye towards the future and how we might be able to reshape our healthcare system when we're able to finally, calm down, take a breath, and get our feet under us.
Adam, I would echo that. One of the things we're looking at is how do we really condition the environment for not just these incremental changes around the edges, and really taking this shift to kind of prospective payment and value-based models seriously. I think that there is a joint understanding that fee-for-service failed the system. And so hopefully that translates into a sustained appetite to move toward those kind of things. But to do that, the conditions are going to need to be favorable to try these things. The environment to fail fast and fail smart, and that we can't have these rigid behemoth structures. We have to be able to test and try these things. So we're working very hard to get that message out.
Thanks. Well, are there any, I know there might be some wonks out there, health policy wonks. This is your chance that you want to throw us any questions before we finish up tonight. And we really appreciate the folks that, who tuned in to talk about this. All right, let's see. Our leader, Walt Mills, has told us we need you more than ever to galvanize us, family physician revolutionaries, to engage and advocate. While the future is challenging, hopefully we can find that in crisis there is opportunity, or as you mentioned, transformation. Yay, good. Any closing thoughts? Anyone?
Yeah, I would just say, reiterate again, we really need your voice in this conversation with legislators, with newspapers, with reporters, with everyone. While we will do our best, inside reaching out to legislators, hearing from the physicians in their district who are seeing their patients, thousands and thousands of patients. You represent a lot of constituents, and you are both healthcare, you are economy, you are jobs, you are all sorts of different sectors of politics all in one. And they need to hear from you. They really need to hear from you. They may be hearing from others or not, and others may be telling a different story. And so they need to hear, not only, on that website, we have our talking points about the messages we want, but the more you can personalize it, the more you can talk about your own practice, people that you know, the better. The more you can talk about your residency program and the effect it has on the community. There is, you can call during the day. That's the best time to reach someone. If you're unable to do that, call at night. Just call. But certainly, if you're able to call during the day, please do that. Take some time at lunch. If you are interacting with your colleagues, have them call as well. We need everybody on board for this. This is crunch time right now. This week is very, very important for you to be active and reaching out to your legislators. All that time that you came to lobby days to start building those relationships, the PAC events you attended, now is the time to be involved.
Adam, let's say Dr. Pan and Dr. Arambula are not, or we are not constituents. Should we call them too?
I think we're okay with them.
Okay.
I'll let Bryce or Vanessa argue against me, but I think our constituents are doing a great job with them. Their constituents are, and they, it is sad and amazing. It's sad that we only have two of them, one in each house, but amazing that they're there. I cannot tell you the effect that has on our ability to really spread our message, because they talk to their colleagues as well, and their colleagues look to them as experts on healthcare. And having them there, especially those two who are just so supportive of patients and of coordinated care and of primary care. They've both been multiple champions of family medicine award winners for us, just to show how amazing they've been. So I think they get it. I think their constituents can do the job, and we don't need to reach out to them if you're not in their district.
Okay.
Yeah, I would say, in addition to your local legislators, so that they understand the community-based impact of what these cuts would look like, would be to also possibly call the Speaker of the Assembly and the leader, the Senate President Pro Tem of the Senate, because ultimately they're the ones who are going into negotiations with the governor. And they're the ones who also need to hear about how these impacts are going to affect their communities.
And we have one other question as to whether emails in this immediate time would be helpful at all.
Only if you have their personal email address. You need to be calling. If you look, they've done plenty of surveys on this. If you look at the value of a fax, of an email, of a form email, and then phone is up here. In person is up here.
But we can't do that right now.
In person is a little bit challenging right now. So probably not going to do that. The very next best thing is phone. Email, if you have a personal connection with them and you have their personal email, that's great. If you can only email, then do that, but you really need to call in. This is a time to call in.
Yeah, and let me just punctuate that a little bit. Just to give you a little hint of a day in the life of a lobbyist in Sacramento. If the CAFP membership is not doing that, and when Vanessa and I go to meet with them in a meeting or testify or what have you, the worst thing we can get is to say, well, we never heard from you. I never heard from one family physician. I've heard from hundreds of teachers. I've heard from all these people. So at this point, it's an exercise in quantity versus quality. Some legislators, listen, there's 120 state legislators, 2 of them are physicians. A majority of the others probably, have a difficulty differentiating between a family physician and a pediatrician. Some offices are just going to say to their staff, some members are going to say, well, how many letters did we get on this bill? Or how many calls did we get on XYZ issue, particularly these budget subcommittee members? So if we can keep that drumbeat going, they are going to get the sense that, wow, this is a huge deal. We got 10 calls just this morning. We're getting all these emails. So it's an exercise, again, in quantity versus quality. There'll be time for quality, but right now is they need to give Adam a call and say, okay, we get it. We're with you. Stop calling, stop the email. And back in the day when there was a fax, thank you for mentioning fax, Adam. Back in the day when there was a fax, there was always a trick of just faxing them so many letters that they can't fax out, they can't do anything. So it's all hands on deck.
And I think we can talk to whoever answers the phone, right? It doesn't necessarily have to ask for anyone in particular.
Yeah, you should also be aware there are, Sacramento is still a shelter-in-place county. The legislature is considered an essential business, but there are a whole host of precautions being taken at the state capitol. Every single legislative office is only allowed to have 1 staff person in the office. And they could rotate that staff person, but the sergeants have to know which staff person is in each office, and they're actually going around periodically throughout the day making sure that there is only 1 staff person in that office. So some legislators are only going into the Capitol, into their office for a couple hours a day, and or sitting in a hearing and then going back to where they live in Sacramento. So whether you actually get a live person or not, whether you get a voicemail, I would just talk to whoever picks up the phone, if depending upon whoever that is.
Yeah.
So
okay.
I just want to say thank you. That's our time. Thank you to everyone who is listening in on Facebook, for Stephanie, for Bryce, for Vanessa, and for Carla. Thank you for all that you guys are doing to fight for family medicine. It's so important right now. I can't thank you guys enough. For those interested, please see us next week. We're going to have our very first virtual residence poster contest where family medicine residents will present their case-based research posters, and you get to ask them questions. Join us at 7:30 next week for our next community conversation. Again, thanks for all you're doing. Get involved this week like you've never been involved before. Feel free to email CFP or AFP with any questions. We're very willing to help out and want to help out. And thank you all for joining us.
Yes, thanks. It was a great hour. Thank you.